You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for September 18th, 2020. This week, COVID, CMR after COVID, a revision of the ISCHEMIA trial, low-risk patients with valvular heart disease. First, a note on COVID. Yes, it is still bad. Deaths per day here in the U.S. are around 1,000 per day. Good news is the Oxford vaccine is back on. Now, one quick comment. People are struggling. American society is struggling. I see a number of patients who want procedures done soon because they lost their job and insurance is running out. More and more, I see patients who are having arrhythmia flare-ups and they believe it is due to stress. Now, I ask these patients, is it stress from the pandemic? Sort of, but many of them it's from the civil and political unrest. Now, if you're retired or out of work or have time, you have more time to watch the news or be on social media. And if that is the case, the news is bad. It's a risk for being despondent. I think we have to remember, as healthcare people, most of us are in a class of people who can keep working during the pandemic. Large swaths of society are not so lucky. I want to read you a quote from March, beginning of the pandemic, from a Stanford scientist. This person wrote that one of the bottom lines is that we don't know how long social distancing measures and lockdowns can be maintained without major consequences to the economy, society, and mental health. Unpredictable evolutions may ensue, including financial crisis, unrest, civil strife, war, and a meltdown of the social fabric. Unpredictable evolutions may ensue. Now, make no mistake, I'm not for letting it rip, but I really wonder when this story is written. I think many will make connections between the measures to contain coronavirus and the accelerations of civil strife. The social fabric of my city of Louisville, Kentucky, has been injured by the death of Breonna Taylor. This week, the city settled with her family for $12 million. I really hope this is the first step in healing. America needs healing. I don't know how much, but I suspect lots of human health stems from the social fabric. I mean, think about it. Human beings are social, and without cohesion, we are surely less healthy. Okay, now to cardiology. CMR and COVID-19. One of the first things you learn in cardiology is that a common cause of cardiomyopathy is viral myocarditis. This is a rare and stochastic event, and it often improves on its own. This week, I was a signatory along with about 50 other medical professionals on a letter to professional societies in cardiology on the matter of doing MRI scans after COVID-19 infection. Professor Venk Murthy from the University of Michigan began the initiative after a handful of studies using CMR raised public fears over the increased risk to the heart in patients following infection. Our main concern with these studies was not the science itself, but the massive misinterpretation of their clinical significance. The short story is that these small, non-randomized observational reports found features of subclinical myocarditis on MRI imaging in patients who had recovered from COVID and may not have even had symptoms. Some commentators have raised concerns that COVID-19 may lead to frequent serious long-term cardiac sequelae, even among people who had mild infection and or possibly asymptomatic. In the letter, we emphasize that the prevalence and clinical significance and long-term implications of these surrogates of heart injury are completely unknown. And worse, we don't even know the meaning of elevated T1 and T2 in general. 3 quick points here. First, remember, friends, abnormalities on CMR such as LGE have been found to be predictive in disease states like ischemic heart disease. Whether these same abnormalities have predictive power in recovering viral infections is completely unknown. Second, abnormalities on CMR have been observed in healthy, long-term endurance athletes. This raises the hugest issue with some of these reports, that is, the lack of control arm. When you find aberrations on a scan of a post-COVID patient, you need to have a control arm to see if these aberrations are there as well. For instance, do athletes who have recovered from influenza or parainfluenza or any of the hundreds of respiratory pathogens also have these same spots on their scans? Without that, the aberrations in COVID-19 patients are of unknown significance. And specifically, in the German JAMA Cardiology research letter that was reanalyzed, there were no longer any differences in the COVID patients compared with the risk factor matched controls. Third issue, the abnormalities previously diagnosed as possible myocarditis have been characterized and described previously in patients with clinical symptoms and signs of myocarditis, things like an abnormal ECG or chest pain, arrhythmias, elevated troponins. So we tried to be candid in the letter about the fact that people are already seeking CMR testing despite the absence of symptoms or signs. I have heard about this from affected individuals, and I have had groups discuss the idea of setting up post-COVID testing programs. This is premature. And the final line of our letter is that in light of your society's standing in the community and advocacy against low-yield testing and low-value medical care, we request that you offer clear guidance discouraging CMR screening for COVID-19 related heart abnormalities in asymptomatic members of the general public. To be sure, none of the signatories, me included, are against studying the potential cardiac implications of coronavirus infection. These efforts should go forward. But to take the data that we have and apply it clinically would be potentially disastrous. The downstream cascades from these scans could cause a tremendous amount of iatrogenic harm. Next topic is the ISCHEMIA trial revisited. This week, ISCHEMIA investigators were back in the news with a substudy that, sit down for this, found a positive p-value for the invasive arm in a tiny subgroup. Now, you recall that the ISCHEMIA trial published earlier this year is one of medicine's most important trials. More than 5,000 patients who had serious coronary artery disease and documented ischemia, people who in my neighborhood always go to the cath lab and get revascularized, these patients were randomized to an early invasive strategy or a conservative strategy of medical therapy first and cath only for failure of medical therapy. All of the priors before ischemia were crystal clear. Every study in patients with stable coronary disease found no reductions in outcomes with adding PCI to optimal medical therapy. And ischemia found the same. The primary endpoint, a composite of CV death, MI, hospitalizations for angina or heart failure, and sudden cardiac death, were not statistically different at 5 years. Death rates in the arms were nearly identical. Notably, over 2/3 of patients in the conservative arm never had cath or PCI. Now pause there for a minute. The majority of patients with documented coronary disease, at least moderate ischemia on a stress test, did not have any revascularization procedure and still had the same outcomes. Another notable feature of ischemia, one highlighted by co-PI, Dr. Judith Hochman, she talked about during her meeting presentation, was the lack of heterogeneity of treatment effect based on coronary artery disease severity, baseline ischemia, or even the presence of LAD disease. For instance, she pointed out that patients with 3-vessel disease did have higher event rates than patients with 1-vessel disease, but nevertheless, there was no advantage to the invasive approach. Now, this study, ischemia, crushed the clogged pipe frame of modern cardiology. But, as Max Planck said, it will take a generation for this message to have clinical effects. Therapeutic fashion and financial incentives are just too great to stop the stress test to cath to PCI cascade in our era. Okay, now to the substudy, which mysteriously was published in Circulation. ISCHEMIA authors asked a reasonable question, and it is, do patients with a history of heart failure or left ventricular dysfunction do better with an invasive strategy? Now remember, you had to have an ejection fraction greater than equal to 35% to get into the trial. Nearly 8% of patients enrolled in ISCHEMIA had either a history of heart failure or an ejection fraction between 35 and 45%. Of these 398 patients, or 8%, with heart failure and left ventricular dysfunction at baseline, 177 of them had heart failure and a left ventricular ejection fraction greater than 45, so like HFpEF. 28 had heart failure and left ventricular dysfunction, and 193 had left ventricular ejection fraction at 35 to 45%, but did not have a history of heart failure. The chief finding of this paper was that in the subgroup that had heart failure and left ventricular dysfunction, there was a benefit in the invasive arm for the primary endpoint and in the secondary endpoint of CV death and MI. And the effect size was quite large. But despite this large difference, the p-value for interaction did not quite make significance at 0.055. Now here is a quote from the paper. This difference in outcomes was driven by a large effect of the invasive strategy on the subgroup of patients with heart failure and left ventricular ejection fraction of 35 to 45%. Now, 3 sentences ago, I told you that this group had 28 patients. 28 patients out of 5,000 in the trial. My friends, these sorts of studies are really problematic. While it's an important area of investigation, as patients with left ventricular dysfunction often go to cath, you simply cannot make inferences from such a small subgroup of patients, especially when the overall finding, remember, the overall finding of ischemia was non-significant. Dr. Sanjay Kaul, an expert on clinical trials, wrote on Twitter that the unadjusted interaction p-value of 0.055 was based on absolute risk difference scale, which is less stringent for exploring interactions, and he noted no interaction on heart failure hospitalizations and a 2-fold increased risk of heart failure hospitalizations in the cohort who had PCI and CABG. He said, quote unquote, smells like a spurious finding with an exclamation point. Now let me diverge here a bit to remember the famous subgroup analysis of the ISIS-2 trial. This is a great story and one that should be taught in medical schools. In 1988, the ISIS-2 trial enrolled about 17,000 patients to prove the benefit of aspirin after myocardial infarction. The Lancet agreed to publish the trial, but with a catch. The editors wanted to determine which patients had benefited the most. Was it older or younger, men or women? One of the senior trialists, named Dr. Richard Pito, refused. He said such analysis would inevitably lead to artifactual conclusions. But the Lancet editors persisted. They declined to advance the paper otherwise. So Dr. Pito sent the paper back, but with a prank buried inside. Get this, the clinical subgroups were there as requested, but he had inserted an additional one, and that is the patients were subdivided into 12 groups according to their astrological birth signs. And he found that Geminis and Libras were found to have no benefit from aspirin, but aspirin produced halving of the risk if you were born under Capricorn. This was an amazing gift for everybody. And I'd actually forgotten that this wasn't a separate paper. This was actually in the original paper. Go look, it's really there in a 1988 manuscript. So let's get back to the super tiny subgroup of patients with heart failure and left ventricular dysfunction and ischemia. The best you could say is, don't dare make anything of it. A more provocative thing to say would be that this type of scholarship should be frowned upon. I do say that to the author's credit, they had plenty of caution statements in there warning readers that this could be due to the play of chance. And we clinicians would be wise to heed their warnings and to apply the main trial findings at the bedside. Next topic today is about low-risk patients with valvular heart disease. Okay, what do you do if you have a 55-year-old patient who has had mitral valve repair and develops AFib? The patient does not have any CHA2DS2-VASc risk, but does have valvular disease. Should he or she be anticoagulated? What if it's a patient with a bioprosthetic valve and 0 or 1 risk factors? A recent study led by a Danish team, published in JACC, tries to sort out the risk of stroke and inform the decision to use anticoagulation in these patients. This paper also taught me something useful about the characterization of valvular heart disease. It turns out that in 2017, an international group of experts put together a consensus statement on using anticoagulation in patients with valvular heart disease. I will link to the document in the show notes. In it, they separate valvular heart disease into type 1 and type 2, ERA type 1 and type 2. Type 1 is moderate to severe rheumatic mitral stenosis and mechanical heart valves, and of course, everybody knows these patients should receive warfarin or vitamin K antagonist. Type 2, though, is everything else. Mitral regurg, mitral valve repairs, AS, AI, TR, bioprosthetic aortic valves. These patients can receive warfarin or DOACs depending on their CHA2DS2-VASc score. So the new paper in JACC looks at these patients who don't have a CHA2DS2-VASc risk factor or have only one. The authors used Danish registries to assess stroke risk in those who had type 2 valvular heart disease who were not anticoagulated. And what the two main findings are that at 1 year after AF, patients with type 2 valvular heart disease had a risk of thromboembolism between 1.2 and 1.5% according to their age group, younger or 65 to 74. In patients with ERA type 2 valvular heart disease who were young, less than 65, who had 0 or 1 comorbidity, the risk was 1.5% and 1.5% at 1 year after the diagnosis of atrial fib, respectively. Now what, the question is? Well, the general consensus holds that if your stroke risk is greater than 1% per year, anticoagulation is felt to be beneficial on net. And this makes sense, but there are caveats. Even in the large Danish registries, these rates of stroke came from quite small numbers of events. The central figure in this paper describes 8 events out of 444 patients at risk. This puts the lower bound of the confidence interval at 0.7% per year, which would be below that 1% risk threshold. I'd say another uncertainty that this paper cannot answer is that type 2 valvular heart disease is a vast category. I mean, is a 64-year-old who has AFib and a bioprosthetic valve the same risk as a 44-year-old runner with mild aortic insufficiency? I don't think so. The authors note the small numbers and wide confidence intervals. And I cover this paper because at least it is some data. Obviously, to know the answer on anticoagulation, you would need a trial, but I don't think that's going to happen because this is a pretty small group of patients that has a very low event risk, and it would take a lot of patients and a long trial to discern any differences. My final comment on this is that low-risk patients that are in this 1% stroke risk per year category cause me a great deal of stress in the clinic. Remember that medical decisions are binary, yes or no on anticoagulation. But here, the benefit in stroke prevention is going to be low because a 50% reduction in a very small stroke risk is very small. A bleeding risk is also low, but it's not zero. You try to get patients involved in this decision, and some do make it easy for you. Some say, I don't want a stroke, I'll take it, or others will say, no doc, I don't want to be on an anticoagulant. But other patients want you to tell them what to do. Ultimately, you make the best decision you can and you reassess next visit and you live with the uncertainty. And so that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider giving us a review, a rating, telling a friend, and that way others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from theheart.org on Medscape.